Let me paint you a picture. You are 68 years old, you feel good. Not perfect, nobody feels perfect at 68, but genuinely good. You sleep reasonably well. You walk 3 mornings a week. You eat carefully. Your blood pressure is under control. Your doctor has told you for years that you are doing everything right. Then one afternoon, a new physician joins the practice. She is thorough, diligent. She reviews your chart and decides to order a full panel of routine screening tests. Just to be safe, just to have a complete picture. 6 weeks later, you are sitting in a specialist's office. Not because you felt anything, not because something went wrong, but because one of those just-to-be-safe tests found something. And that something, a finding your previous doctor might have looked at and said, "Let's watch it," has now been flagged, referred, biopsied, and scheduled for a follow-up procedure. And suddenly the life you were quietly living well looks very different. That exact story plays out in clinics across this country every single week. And the data behind it, data that physicians in Japan and South Korea have been acting on for decades, deserves a serious, honest conversation. Because the risk-benefit math of routine screening changes dramatically after the age of 65, and almost nobody in a standard appointment is doing that math with you in the room. My name is Dr. Jae Yoon. I am a physician trained in both Western clinical medicine and traditional East Asian integrative medicine. For 26 years, I have studied a question that most Western medical systems have been slow to ask. Why do adults over 65 in Japan and South Korea experience dramatically lower rates of iatrogenic harm, that is, harm caused by medical intervention itself, compared to their counterparts in the United States? The answer is not that East Asian medicine avoids treatment. It is that it applies a fundamentally different threshold for when intervention is warranted, and when watchful patience is the superior clinical choice. Today, I am going to walk you through 5 specific medical checkups that I would personally reconsider after the age of 65. I will tell you what the peer-reviewed evidence actually shows. I will share what I have seen happen to real patients. And at the end, I will give you a set of questions that will completely change the dynamic of your next doctor's appointment. Stay with me through all 5, because number 3 is the one that surprises people most, including physicians who order it every single day without hesitation. And number 5 is the one that almost no patient I have ever met knew anything about, until they were already sitting on the other side of a decision they could not take back. Before we get into the 5 checkups, I need to give you one framework, because without it, nothing I am about to share will fully make sense. I call it the intervention threshold, and it is the single most important concept that separates how geriatric medicine is practiced in East Asia from how it is practiced in the West. Here in the United States, when a test finds something, the default response is to treat it. That default made excellent sense when it was established. It was built on data from younger populations, where early detection reliably led to better outcomes, and where bodies had the reserve to tolerate aggressive intervention. The logic was sound. Find it early, treat it fast, save a life. But after 65, 3 things change that break that logic. First, many of the conditions that routine screening finds in older adults will never actually harm you. They grow slowly. They cause no symptoms. You will, in all probability, outlive them. But the moment they appear on a report, the medical system does not have a watch and wait mode built into its default response. It has a treatment mode, and treatment mode activates. Second, your body's tolerance for intervention decreases with age in ways that most people do not fully understand until they are in the middle of a recovery they were not prepared for. The surgery that a 55-year-old navigates in 2 weeks can mean months of complications, lost independence, and a fundamentally altered quality of life in a 75-year-old with the same diagnosis. Third, and this is the one I want you to remember, there is the cascade effect. One test finds a small abnormality. That abnormality triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And a person who walked into a routine appointment feeling completely well is now navigating a medical system from a position of illness that the system itself created. This is not a failure of medicine. It is a failure of calibration. And calibrating correctly for your age and biology is exactly what I want to help you do today. Before we begin, tell me in the comments where you are watching from. I read every single one. And tell me, Have you or someone you love ever had a routine test lead somewhere unexpected? Your experience might be exactly what someone else needs to hear before their next appointment. Let's begin. Checkup number 1. Routine colonoscopy in average risk adults after age 75. I want to tell you about a patient I will call Margaret. She was 77 years old. She had been my patient for 4 years by the time this happened. Retired school teacher. Sharp, funny, completely independent. She gardened every morning, drove herself everywhere, and had never, in 4 years, missed a single medication dose or a single follow-up appointment. Margaret had 2 colonoscopies in her 50s and 60s. Both were completely clean. No polyps, no family history of colon cancer, no symptoms of any kind. But when she changed insurance and was assigned a new primary care physician, that physician looked at her chart, noted that her last colonoscopy was 11 years ago, and said the words that set everything in motion. "You are due for another one." Margaret called my office to ask what I thought. I told her what the evidence says. The United States Preventive Services Task Force, the gold standard body for screening guidelines in this country, officially recommends against routine colonoscopy screening for average risk adults over the age of 75. Not as a suggestion, as a formal recommendation against the procedure for patients in her exact situation. She asked her new physician about this. He said the guidelines were conservative and that he preferred to be thorough. She went. The bowel preparation, the osmotic laxative solution required to clear the colon the night before, hit her kidneys hard. By the following morning, she was confused, dizzy, and barely able to stand. Her daughter found her on the bathroom floor and called an ambulance. By the time she arrived at the emergency room, her electrolytes were so dangerously disrupted that her heart was showing irregular rhythms on the monitor. Margaret spent 5 days in the hospital. She never had the colonoscopy. And the thing is, she did not need it. Not because I am dismissing the importance of colon cancer screening, but because in her specific clinical situation, the evidence clearly did not support it. Here is what most patients are never told. Bowel perforation, a literal tear in the wall of the colon, occurs in approximately 1 in every 500 colonoscopies. In a younger adult, that is a manageable surgical complication. In a 77-year-old, it can mean emergency surgery, a permanent colostomy, months of hospitalization, and a recovery that permanently changes what you are able to do independently. And the colon cancers most likely to be found in asymptomatic adults Margaret's age tend to be slow growing. Slow enough that in many cases they would never cause problems within a person's remaining lifetime. This is precisely the intervention threshold I described. The risk of the test, in her specific situation, was greater than the benefit. What to do instead? For adults over 75 who are average risk with no symptoms, ask your doctor about stool-based testing. The Cologuard DNA test or the annual FIT test can identify genuinely concerning signals without any procedural risk whatsoever. If you do have symptoms, blood in your stool, unexplained changes in bowel habits, new abdominal pain, that changes the equation entirely. See your doctor immediately. Symptoms are a different clinical situation from routine screening. But if you feel well and your previous scopes were clean, you deserve to have this conversation before you consent. Checkup number 2. Aggressive PSA prostate testing and routine mammography follow-up in low-risk, asymptomatic individuals. Let me be precise here because this topic is too important for imprecision. I am not saying do not screen for cancer. Cancer screening has saved lives and will continue to save lives. What I am saying is that after 65, in average-risk, asymptomatic individuals, the overdiagnosis problem in cancer screening is real, it is documented, and it is causing harm that nobody in a standard appointment is measuring or disclosing. Overdiagnosis means detecting a cancer that is biologically indolent, growing so slowly that it would never cause symptoms, never spread, and never shorten your life. You would die with it, not from it. The problem is not finding it. The problem is what happens next. Because the moment a radiologist or pathologist writes the word malignancy on a report, the clinical system activates completely, regardless of whether activation is warranted. I had a patient, I will call him Robert, who was 79 years old, retired engineer, still sharp, still active, still doing the crossword every morning and playing chess online in the evenings. His PSA came back slightly elevated at a routine appointment. Biopsy confirmed a low-grade, slow-moving prostate cancer. His urologist, a good physician, a careful physician, recommended radiation therapy. Not because he was trying to overtreat, because that is what the protocol said. And Robert trusted him. Within 8 months of completing radiation, Robert was dealing with chronic fatigue that had not been there before, urinary complications that required ongoing management, and a quality of life that had dropped in ways he described to me as irreversible. He told me once, quietly, near the end of an appointment, "I think I treated something that was never going to hurt me, and the treatment hurt me instead." That experience is documented extensively in the medical literature. A landmark study in the New England Journal of Medicine found that a substantial proportion of cancers detected through mammography in women over 70 were clinically insignificant, meaning that treatment provided no survival benefit, only side effects. South Korean oncology guidelines, revised in 2016, formally incorporated biological age thresholds into cancer screening recommendations specifically because of this data, a step that measurably reduced overtreatment rates in that country. What to do instead? If you have a family history, known genetic markers, or any symptoms, screen. That is not what I am questioning. What I am asking you to consider is this. If you are average risk with no symptoms, ask your physician one specific question before agreeing to a screening test. If we find something, what are the realistic treatment options for someone my age and current health? And would we actually treat it or watch it? That single question often transforms the conversation in ways that serve you far better than simply following a protocol that was not designed with your specific biology in mind. Checkup number 3, routine cardiac stress testing without symptoms. This is the one that surprises people because it sounds so responsible. Your doctor says you are 72, let's just make sure your heart is doing well. You walk on a treadmill. Someone monitors your heart's response. What could be wrong with that? Here is what is wrong with it. Cardiac stress tests in adults over 65 who have no cardiac symptoms have false positive rates that can reach 40% or higher. That means that in nearly half of cases, the test flags an abnormality when your heart is actually functioning normally. The flag is a product of the test's limitations interacting with the normal physiological changes of aging. Baseline changes to the electrical pattern of the heart, stiffening of the left ventricle, chronotropic incompetence. Changes that are entirely normal at 65 or 70, but that a stress test cannot distinguish from pathological findings. But medicine cannot simply look at an abnormal finding and shrug. The flag launches you into the next stage, and the next stage is cardiac catheterization, threading a thin guide wire through the vessels of your wrist or groin directly into the coronary arteries of your heart. It is a serious procedure. The risks include arterial dissection, acute myocardial infarction, stroke, and, in a small percentage of cases, it can trigger the very cardiac event you came in to prevent. And if the catheterization finds a partial blockage, which is extremely common in adults over 65, the vast majority of whom have absolutely no symptoms, you may be looking at a cardiac stent. This is where the evidence becomes genuinely counterintuitive. The ischemia trial, one of the largest and most rigorous randomized controlled trials in cardiovascular medicine, enrolled over 5,000 patients and found that stenting in patients with stable coronary artery disease produced no reduction in heart attacks and no extension of life compared to optimized medical therapy and lifestyle management alone. Let me say that clearly one more time. The stent did not outperform the medication and the 30-minute daily walk, but the stent carried procedural risks, required a lifetime of blood thinners with their own bleeding complications, and generated years of monitoring and follow-up. You went from feeling well to a routine test, to a false alarm, to a catheterization, to a stent, to blood thinners, and you ended up statistically no better off than if you had simply optimized your blood pressure, your cholesterol, your blood sugar, and your activity level. This is the cascade effect in its clearest form. What to do instead? If you have no chest pain, no unexplained shortness of breath, no dizziness or lightheadedness during activity, routine cardiac stress testing is generating findings in a population where findings are common and intervention does not reliably help. The conversation worth having with your physician is not about ordering a stress test. It is about your actual modifiable risk factors: blood pressure, lipids, blood sugar, activity, sleep, where the evidence for benefit is clear and the risk is essentially zero. If you are finding value in this conversation, take a moment right now and leave a comment. Tell me what you are most surprised by so far. I read every response, and this conversation matters more when I know who I am having it with. Checkup number 4, routine DEXA bone density scanning with automatic bisphosphonate prescription. I want to be careful here because this is a topic where nuance matters. Osteoporosis is real. Falls are devastating. Hip fractures in older adults are associated with mortality rates that most people do not realize. And I am not in any way dismissing the seriousness of bone health after 65. What I am questioning is the clinical pipeline that often follows a DEXA scan result in otherwise healthy older adults. The automatic conversion of a T-score into a long-term prescription without a detailed conversation about what the medication actually does, what the evidence shows at your specific age and fracture history, and what the documented long-term risks are. Bisphosphonates, medications like alendronate and risedronate, accumulate in bone over time. They are the most commonly prescribed treatment after a low DEXA score. And in specific patients, those who have already had fractures, those with very low T-scores, those with specific clinical risk factors, they have a meaningful role. I prescribe them. I believe in them for the right patient. But here is what is almost never mentioned at the point of prescription. Long-term bisphosphonate use, meaning 5 years or more, has been associated with atypical subtrochanteric femoral fractures. These are spontaneous stress fractures that occur in the thigh bone, the very bone you are taking the medication to protect. They are rare, but they are real, and they are severe, often requiring surgery and extended recovery. There is also a documented association with osteonecrosis of the jaw, progressive bone deterioration in the jaw that is painful, disfiguring, and extraordinarily difficult to treat, particularly following dental procedures. And here's the piece that I think changes the entire conversation. The most effective intervention for preventing fractures in older adults, bar none according to the evidence, is not a medication. It is fall prevention. Balance training programs, specifically Tai Chi, have been shown in multiple studies to reduce fall risk by close to 50%. Removing tripping hazards from the home, installing grab bars at the toilet and shower, reviewing all medications for side effects that cause dizziness or orthostatic hypotension, having vision checked regularly, ensuring adequate protein and vitamin D intake. In Japan and South Korea, structured fall prevention programs have been integrated into geriatric care for decades. They are not considered alternative or supplementary. They are considered primary intervention because the evidence supports them. What I want you to take from this is not that you should refuse medication if your physician recommends it. What I want you to take is the right to ask one specific question before you begin. Can we review my actual fall risk factors in detail? And can you show me the comparative fracture risk reduction between this medication and a structured fall prevention program for someone with my specific score and fracture history? A good physician will welcome that question. The answer will help you make a decision that is genuinely informed rather than automatic. Checkup number 5. Asymptomatic carotid artery ultrasound screening. This is the one that almost nobody has heard of, and based on what the research shows, it may be the most consequential of all 5. A carotid artery ultrasound examines the large blood vessels in your neck that carry blood to your brain. The premise is straightforward and it sounds entirely logical. If we find a significant blockage, we can surgically remove it and prevent a stroke. It sounds like exactly the kind of proactive medicine that should save lives. The clinical reality for asymptomatic patients is more complicated and more dangerous than the premise suggests. The surgical procedure used to treat significant carotid stenosis is called a carotid endarterectomy. It involves opening the artery, removing the plaque, and closing it. It is a major vascular procedure, and it carries a documented 2 to 3% risk of causing a stroke or death during or immediately following the surgery. In older adults with additional cardiovascular risk factors, that risk is measurably higher. The United States Preventive Services Task Force does not recommend against this surgery in symptomatic patients, but for asymptomatic individuals, people with no TIA, no sudden vision changes, no facial weakness, no unexplained neurological episodes, they recommend explicitly against routine carotid artery screening. Their formal analysis found that for asymptomatic patients, the procedural risk of harm from the surgery exceeds the benefit of preventing strokes. Here is the biological reason why. Many adults over 65 have some degree of carotid narrowing. That narrowing is often stable. It has been there for years. It is calcified fibrotic plaque, not actively rupturing, not generating emboli, not causing symptoms. When you screen routinely, you find it. And when a well-meaning vascular surgeon sees it, they recommend fixing it. But the act of surgical intervention on plaque that was stable can dislodge embolic material that travels directly to the brain. The surgery causes the stroke it was meant to prevent. I am not going to walk you through a single patient story for this one. The documented outcomes in the medical literature are too significant to reduce to one case, and I want you to hold the full weight of what I am saying. People have walked into routine screening appointments feeling completely well and left on a trajectory they never anticipated, not because of the blockage that was found, but because of the intervention that followed. What to do instead? If you have no neurological symptoms, and I mean none, no sudden vision changes, no facial drooping, no arm weakness, no sudden severe headache, then routine carotid ultrasound is not supported by the evidence for your situation. The investment with the clearest clinical return is controlling your actual modifiable stroke risk, blood pressure above all else, which is the single most powerful driver of stroke risk, blood sugar management, atrial fibrillation detection and management, stopping smoking, and structured aerobic activity. If you experience any neurological symptom, even briefly, even if it resolved completely in minutes, get evaluated immediately. That changes the clinical picture entirely. But in the absence of symptoms, you deserve to know that a test can find something that leads to a procedure that causes the very outcome you were trying to prevent. The 5 questions. I promised you something practical. Here it is. Every time your physician recommends a screening test, especially after 65, especially when you are feeling well, I want you to have these 5 questions written down in your phone. Bring them to every appointment. Question 1. What is the false positive rate of this test in adults my age? This tells you how likely the test is to generate a finding that leads to procedures even when nothing is actually wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and current health status? And would we actually treat it or monitor it? This moves the conversation from what can we find to what will we do if we find it. Question 3. What is the procedural risk of any treatment we would likely pursue? Most patients never ask this. Every procedure has a risk profile. You deserve to know it before you consent to the test that leads to the procedure. Question 4. What does the evidence show about watchful waiting versus immediate intervention for this finding in adults my age? For many conditions detected in older adults, active monitoring is a completely legitimate and often superior clinical choice. It deserves to be on the table. Question 5. What is the most effective non-invasive intervention available for this condition? Because very often, as with bone health, cardiac health, and stroke prevention, lifestyle optimization and medication outperform procedural intervention with a fraction of the risk. Any physician practicing evidence-based medicine will not only answer these questions, they will respect you more for asking them. If your physician dismisses these questions or makes you feel difficult for raising them, that is meaningful information about whether that physician is calibrated to serve your interests at your age. I want to close with something I believe deeply. There's a difference between medicine that finds things and medicine that helps you live well. After 65, the goal of your healthcare should not be to generate findings. It should be to protect your quality of life, your independence, your energy, and your ability to do the things that matter to you. The physicians I respect most in both Western and East Asian medical traditions understand that doing less, when less is what the evidence supports, is not passivity, it is precision. That recommending watchful patience requires more clinical courage than ordering another test. That the question is not what can we find, but what, if we find it, will genuinely help you live better. You have the right to know what a test is looking for. You have the right to know what happens if something is found. You have the right to ask whether that finding would be treated and whether that treatment would genuinely improve your life or simply generate more findings. Medicine has given us extraordinary tools, but tools only serve you when they are used at the right time, in the right context, for the right person. You are that person, and you deserve a healthcare experience built around your goals and your biology, not around a protocol designed for someone half your age. If this conversation gave you something you did not have before you watched it, subscribe to this channel. I publish research like this every week, translated from both Western clinical literature and East Asian medical practice into plain language you can actually use in the room with your doctor. Leave a comment below. Tell me which of these 5 surprised you most. Or tell me if you have a story, because your experience, shared here, may be exactly what someone else needs to hear the week before their next appointment. And share this with one person you care about who has a medical appointment coming up. Not a group message, one person. That specific gesture could change the conversation they have with their doctor in a way that genuinely matters. Dr. Jae Yoon, the science Asia has always known. Take care of yourselves. I will see you in the next one.